How much do we care? Does it really make any difference?
What do you mean by goes off?
Well, like when you came in, it just said recording. It was no longer showing what was on the screen.
We wanted to show, otherwise I don't think it's recording if we don't have the PowerPoint up there. So, right now it's recording what's on the PowerPoint and what's going on here.
Well, we want it to be the way it is now.
Correct.
But when you came back in, it was not showing what was on the screen. Do we care?
I don't think it actually records what's on the screen if it's not showing. I could be wrong. You have a sheet.
Your brain is going in my head. Yeah?
Thursday.
Yeah, we only want to be. We only have wow. Yeah. But I'm not there now. No. They're not there anyway. No, yesterday.
What my memory? Did you have Herpesviridae or something?
Yeah, I did.
Well, still itch right there.
I'm glad it was a year or so. But I'm talking about some complicated.
Well, it was something fun, but it was not nearly
Not
as
us.
bad.
I got bone pain.
But I don't know, it still itches right here. No matter what. I don't think it's the same thing. I think it's something evil and scientific. Do the diagnosis.
I'm sure I'm a little quieter. That's everybody's favorite. I know.
Yeah, the surgery actually. So.
She take it.
No, but they have now. I saw it.
You got a minute when you're through, come by. I'll talk to you about something real brief. Yeah, but she probably 200. That was all, you know, she took it
Oh, by the way, I have my
2 hours altogether. I went to her studio one time. And she told me I didn't like something. She changed it up. And the only thing the sleeves of my coat were too long. I had folded them. I folded them up and she came and folded up. I'm going to get started. I invite comments as I go along. I'll have to sit down during most of this, so I won't see if you raise your hand or something, but just interrupt me as we go along, and that I appreciate some comments, particularly during part of this. Thank you. Herpes-Zoster, or shingles, is due to the reactivation of the varicella or chickenpox virus. The Varicella-Zoster virus is one of the family of Herpesviridae. At the time of the chickenpox primary infection, it enters, that is, the virus enters cranial and spinal sensory ganglia, where it remains latent for a variable period of time. The initial manifestation of herpes-zoster is pain, tingling, or itching, and maybe all of them, followed by a vesicular eruption after a few days, all in a dermatomal distribution. I'll repeatedly mention that there's not always a rash. This vesicular eruption does not always occur. The pain continues for a variable period of time and may be severe. It usually subsides within 4 weeks. Decreased sensation is usually present, and uncommonly localized weakness and muscle atrophy occurs. Infrequently, 2 or more adjacent dermatomes are affected. The thoracic, spinal, and cranial nerve sensory ganglia are most commonly involved. That is, as opposed to the cervical and lumbosacral ganglia. And this is thought to be due to the length of the axon. These are the shorter length axons from the skin to the ganglia, and this is thought to play a role why these are most commonly involved. And here is a picture of herpes-zoster. You can't see vesicles real well. Obviously, the rash does not involve the entire area of the dermatome. It's spotty. It's limited how much they show us here, but because it goes down in the arm there, I think this is T2. The distance across here is pretty broad for a single dermatome, but I don't think T3 is involved because it doesn't go on down through there. I might mention this. The areas of dermatomes have been determined by different mechanisms, and this is one of the mechanisms. And if you watch different dermatomes demonstrated, not all are the same. That is, one book will use one, another the other, and they're not always exactly the same. And this is what I'll more want to focus on. I'm going to read this and then I'll come back and talk a little bit more about aspects of it. Additional diseases caused by reactivation of Varicella-Zoster virus, postherpetic neuralgia or neuropathy, and this is defined as continued pain longer than 3 months after zoster. This can be excruciating pain. Vasculopathy, particularly after zoster of the ophthalmic division of the trigeminal nerve. And at one time I thought that was the only time that it occurred and that it was always on the same side as the zoster, but that is not true now. That's known not to be true now. Increases the risk of stroke, can be multifocal, and can involve the temporal artery. Now back to the different types. Reactivation can cause a myelopathy, which doesn't always, but can produce an infarction in the spinal cord. It can produce a picture of meningoencephalitis, and it can cause retinal necrosis, which occurs acutely and chronically. All of these can occur without the rash, and in the past, this has been called Herpesviridae. Someone, probably some young person, changed this up and now calls it zoster sine, and I don't know how to pronounce that, herpetide. Is somebody an expert on pronouncing these things? So, because I can't pronounce that, and zoster is used to mean the rash, so I like Herpesviridae. And they can occur some months after the rash, particularly the vasculopathy and myelopathy. And in fact, there's a report, it is reported, that in the patients with the vasculopathy, a third of them have no history of having had a rash and do not have abnormality in the cerebral spinal fluid. Well, talk primarily about vasculopathy, a little bit more about postherpetic neuropathy. Pain is bad, can be very difficult to treat. About a year ago, it was reported that treatment with an intense treatment with a IVA cyclovir at the time of the diagnosis of the postherpetic neuropathy does result in improvement, even though these patients may have already been treated with either valacyclovir orally or IV acyclovir. Another fairly recent treatment is peripheral stimulation. With the vasculopathies, this particularly occurs after zoster of the ophthalmic division of the trigeminal nerve, increasing the risk of stroke. It is reported that by the time you reach 80, 50% of people have had herpes zoster, and 30% have experienced a vasculopathy with subsequent stroke. And if the zoster was in the division, ophthalmic division of the trigeminal nerve, it increases the risk of stroke by 4.5 times. And this within the year following the rash or the herpes zoster. The strokes can be ischemic, and years ago I thought that was the only way, but they can also be hemorrhagic. And in addition, there have been reports that it can cause intracranial aneurysms, arterial dissection, and subarachnoid hemorrhage. I've not pursued to see how well those things have been verified. The fact that the strokes are not infrequently multifocal, it can and this can occur over a period of days, weeks, and probably months, because the vasculopathy can be chronic, can mimic the picture of embolic strokes. And as it says here, and as I said, can involve the temporal artery. And there are reports of it mimicking giant cell arteritis, and reports that in patients biopsied for giant cell arteritis, in which it was negative for giant cell arteritis, varicella-Zoster antigen has been found in the adventitia of the artery, and these patients have been treated with a cyclovir. This is of no great note or importance, but I've always objected to referring to giant cell arteritis as temporal arteritis, which it has commonly been in textbooks, because the temporal artery is not always involved in giant cell arteritis, and there are other arteries that are, particularly involving the eye. I'm not going to say anything more about this. I already said there are two types of retinal necrosis, acute and chronic. Acute is painful, chronic is not. And as I've told you, I will repeatedly say, remember that absence of a history of rash does not rule out any of these conditions. The basic is that my purpose with all this is having herpes zoster is potentially bad. The incidence, the reactivation of the virus, that is the occurrence of any of those, increases with age. Approximately 30% of patients with herpes zoster over the age of 60 years old develop postherpetic neuropathy, which, as I've said, can be excruciating pain. I've already told you this, but I'll repeat it. It is estimated that by age 80 years, 50% of people will have had one attack of herpes zoster. And I haven't told you, 1% will have had 2 attacks. And I think that's significant, again, in what my main thrust here. The basic thing for the reactivation is a decline in the varicella-Zoster immunity, and this is what increases the incidence of these reactivation diseases. Immunosuppression increases the incidence, I'm repeating myself, and to show associated illnesses, I've seen these statistics reported. Approximately 5% of patients with herpes zoster have a malignancy at the time, which at least suggests that the malignancy has played a role in decreasing their immunity to the virus. And particularly with Hodgkin's disease, this is the highest statistic I've seen with any associated illness. It's reported approximately 25% of patients with Hodgkin's disease develop herpes zoster. In 1995, the varicella vaccine use started in the United States. From 2000, now this is for chickenpox. From 2000 to 2005, one dose was used and the incidence of chickenpox decreased 43%. They then changed and started using 2 doses, and from 2006 to 2010, 2 doses were used, and the incidence decreased 72%. People immunocompromised due to hereditary immunodeficiency, hematologic malignancies, or immunosuppressive medications should not be given this live attenuated virus vaccine, that is the chickenpox vaccine. In 2006, Zostavax, a live attenuated varicella-Zoster vaccine, was approved by the FDA for immunocompetent people. They didn't define immunocompetent people, age 60 years old and older, and that's a point in a factor in one point that I'm going to review with you. That is, they reviewed it only for people 60 years and older. And with no history of recent zoster, and over the years, I've wondered, what is recent zoster? Is that a week or 2 ago, a month or 2 ago, or a year ago? And again, I'm going to pursue this point. For a period of time, it was controversial to give the vaccine in someone who has had herpes zoster in the past, but you can have a second attack and even more than that. And there are reports now that at least there's no undesirable effect by treating somebody with the vaccine who's already had herpes zoster. These statistics I'm going to give you next come from a report in the New England Journal of Medicine in 2005, which was a phase 3 study for approval of Zostavax. And the first statistic is approximately 70% of the people had a decrease. Pardon me, I'm going to reword that. 70% in the 50 to 59 years old age group were decreased relative to placebo. Note that in this trial, they actually used it for 59 years of age, but it's only been approved for 60 and older. 64%, now again, all of these are relative to placebo. Zoster vaccination decreased the incidence of zoster 64% in the 60 to 69 years age group, 41% in the 70 to 79 years age group, 18% in the 80 years and older age group. Although, as we'll see in the next slide, these people are helped a lot in terms of postherpetic neuropathy, in that again in the 5%, I better just read it, vaccinated people who developed zoster postherpetic neuropathy was decreased 5% in the 60 to 69 years age group, 55% in the 70 to 79 years age group, 26% in the 80 years and older age group. The difference in this 5% to 55% is striking. It's not readily apparent to me why that would occur. I didn't try to look up what the sample sizes were, and would wonder if that's just not a sample problem.
Dr. Lucy,
Yeah.
can I ask you a question?
Yeah.
How long did they follow these people after they were vaccinated?
I don't remember exactly, but it was years. Well, yeah, that's right. If that's not right, I'll let you know. But it was a long time.
Okay.
Other zoster-related problems were also decreased. Immunodeficiency and immunosuppression are contraindications to the use of the Zostavax because of the risk of disseminated or generalized varicella-Zoster infection, which can involve Zoster and can be fatal. And if you have someone who's immunodeficient, it obviously also may affect the obtaining the desired immunization to the varicella-Zoster. I'm going to present two cases, both of them very brief, and they're fairly simple, but the second one will have some aspects different from this one. And these are both people that for a few years I have wondered if they should receive the vaccine. This gentleman, 74 years old man, diagnosed with myasthenia gravis in 2005, manifest by upper eyelid ptosis and dysphagia. Other illnesses that he has have been cancer of the prostate and hypertension. The cancer treatment was completed 5 years ago, and he is thought to be doing well. He continues to see his radiation oncologist 2 times a year, and she's seen him this year and just wants to, as far as her workup is concerned, he's doing well. She just wants him to come back in another 6 months. I wrote here, the myasthenia gravis has been in remission for 5 to 6 years. I think it has, but more accurately, I should have said, his myasthenia gravis has been asymptomatic, and I've not been able to find any manifestation of it on neurological examination for 5 to 6 years. However, that's a problem in that remissions are common with myasthenia gravis. In most instances, they're temporary, but literature says that about 1 out of 10, and my experience would be it probably is that many, go into a permanent remission. The problem is in knowing, are they in a remission, and if so, is it permanent, or are they asymptomatic because of the medicine that you're on? And I don't know any way to find out other than trying to take them off the medicine. And many myasthenia gravis patients are very resistant to that, and this man's one of them. However, in 2013, I'm not going to go into detail, but by 2 mechanisms, he was only taking 50 milligrams of azathioprine per day. And on 6/12/14, he agreed to discontinue it. At that time, I didn't know how long he should discontinue it before taking the vaccine. I think this is interesting. Through all these years, this man has wanted to keep a supply of pyridostigmine bromide. Pyridostigmine bromide only treats the symptoms, but it works within minutes if it's going to work, and it'll work 90% of the time to some extent with myasthenia gravis patients. And if you come off of it, there's no lasting deficit. That is, you can come off of it, and I'll say some more about that, I guess, in the next patient who did come off of his while he was taking it. So he had agreed to discontinue his azathioprine, asked for another prescription of pyridostigmine bromide, which we gave him. I've given you some statistics on him relative to his azathioprine. His blood level when he was taking it at 50 milligrams a day would be 0.56 milligrams per kilogram per day. And for some time, years, I've debated should he receive the Herpes-Zoster vaccine. Case 2, similar, gentleman's a little older, 86-year-old gentleman diagnosed with myasthenia gravis in 2004, manifested by upper eyelid ptosis, diplopia, and again dysphagia. A problem which conceivably can be life-threatening. And additional illnesses that he had include type 2 diabetes mellitus. In 2012, he had Herpes-Zoster without any known associated Varicella-Zoster disease. So he was lucky, and I considered that I was lucky too. After being free of symptoms and signs on my examination, and this is worded better than I did with the first one, myasthenia gravis, for a few years, he agreed to decrease his dose of pyridostigmine bromide, 60 milligrams, from 3 times per day to 2 times per day by dropping the before breakfast dose. Now, a point that I'll throw out, although it's not a main point of this talk, particularly if somebody has a history of dysphagia and they can tolerate it, I always want to give the pyridostigmine bromide before meals. Some people have trouble tolerating that. This man agreed to stop the pyridostigmine bromide, but in 3 months he started having diplopia again. So if he was in a remission, it was a temporary remission. He immediately went back to his before each meal pyridostigmine bromide, and we're lucky in that just taking it those 3 times lasts him all through the days. This man is remarkable. He's 86 years old, has a little farm that he doesn't really farm, but he'll go out and work in that farm for several hours. His wife goes with him and sits in the truck to watch him. In 2014, then, he continued on pyridostigmine bromide, 60 milligrams, 3 times per day before meals, and azathioprine, 50 milligrams, 2 times per day. And I've given you some statistics regarding that. He's now taking 1.14 milligrams per kilogram per day of azathioprine and the pyridostigmine. Should he receive the Herpes-Zoster vaccine? I've looked for answers to this, see if there's any guidelines in the American Academy of Neurology. Haven't found any. In fact, I haven't found any guidance on it up until earlier this year. And then this was published. This came out in Clinical Infectious Disease, February 1, 2014. The head is 2013 IDSA, and the IDSA is the Infectious Disease Society of America. And these are their clinical practice guidelines for vaccination of the immunocompromised host. And I'm a fan of theirs. They say this is an evidence-based guideline for vaccination. I'm going to show you their approach to this is, say, different than what the Institute of Medicine, American Academy of Neurology seem to be pushing on it. I am going to show you this. They, on page 1, say, the Infectious Disease Society of America considers adherence to these guidelines to be voluntary, with the ultimate determination regarding their application to be made by the physician in the light of each patient's individual circumstances. I don't look at all texts, but I think all texts have something like this in them. And this is for legal reasons. How dangerous do you think this is to the Infectious Disease Society of America? Anybody want to comment?
How dangerous to make this statement?
No, to print these guidelines.
If they have this disclaimer, it's probably not that dangerous.
Tell me that again.
I would think if they include this disclaimer, that it's probably not that dangerous.
Well, I think so too. But I haven't researched that point, and I'm going to show you this. There are potential legal implications from these guidelines, both for the source of the guidelines and treating clinicians. In 2008, an Attorney General in Connecticut challenged the Infectious Disease Society of America, contending that their guidelines suggested that the medical evidence did not support prolonged antibiotic treatment for Lyme's disease, which amounted to restraint of trade because third-party payers were relying on the guidelines to deny reimbursement. And part of this Attorney General's workup, threatening lawsuit, he also subpoenaed documents from the American Academy of Neurology regarding its guidelines for Lyme disease. This never went to trial. There was an out-of-court settlement on this, and I don't know, the Attorney General, I don't think, gave up anything except agreed not to go to court. The Infectious Disease Society agreed to restudy the issue, which they did. They came to the same conclusion they had in the first place. And I don't want to take a lot of time, but I'm going to go a little tangent on Lyme's disease, and I'm going to watch the clock because I don't want to spend too much time on it. Lyme disease, the incidence of Lyme disease varies greatly geographically. It was originally described in the New England state, I think it was Vermont.
Connecticut.
Connecticut?
It's very close to Geneva, actually. That's why
Is that right? Well, you know, it was originally described on a group of children that had what was first diagnosed as rheumatoid arthritis, because both the chronic disease, and I haven't kept up with the terms, but the late effects in chronic diseases are manifest most often rheumatologically, but can be neurologically too. But it was Connecticut.
It's called Old Lyme. It's a little town on the coast that's about 15, 20 miles from Geneva.
And one of the New England states, there was a report a number of years ago that they had found Lyme's disease to be the etiology for Bell's palsy more often than herpes simplex, which I think is generally thought to be the most.
You mean Zoster?
Pardon?
You mean Zoster?
No, I think Bell's palsy is with herpes simplex.
Oh.
I think that's thought to be the most common. Now, I've never seen a case, I've never knowingly seen a case of Lyme's disease in Arkansas. I have seen patients like they're talking about here, patients who thought they had this late effect and were trying to find a doctor to give them a long-term antibiotic treatment. Patients I saw, I didn't try to decide. They had already seen infectious disease, or I asked infectious disease, and infectious disease said they didn't have. And in fact, I don't think a case of Lyme's disease has been confirmed by the State Health Department in Arkansas since 2007. Has anybody here come from someone, or the other way around, residents may go to an area where Lyme's disease is fairly common up in the Northeast? And here is another point that they list in this. An asterisk indicates recommendation for a course of action that deviates from recommendations of the Advisory Committee on Immunization Practice Centers for Disease Control and Prevention. And that is these guidelines, and I'll show you, because the guideline that this applies to is one that I'm interested in, I'm presenting to you. They delineate 8 levels of recommendation and quality of evidence, and I'm showing you only the 3 that are relevant to what I want to show you. And they did an extensive literature review. And one is, they say, strong recommendation, low quality evidence. Now, if you go on down, here's the next one, very low quality evidence, and again, low quality evidence. If it's strong recommendation, low quality evidence, their opinion is that for our case, the desirable effects clearly outweigh undesirable effects. And this is the way they evaluate this. They say this group had evidence for at least one critical outcome from observational studies, randomized controlled studies with serious flaws or indirect evidence. Again, strong recommendation, but very low quality evidence. They say very rarely applicable, but to repeat myself, there's one that I'm interested in, that it is applicable. They say desirable effects clearly outweigh undesirable effects, and they again give the line of evidence, at least one critical outcome from unsystematic clinical observation of very indirect evidence. Weak recommendation, again, low quality evidence, uncertainty in the estimate of desirable effects, harms, and burdens. Desirable effects, harms, and burdens may be closely balanced. Although, here's one that if I was a patient, as we'll come to in a minute, I'd consider. Evidence for at least one critical outcome from observational studies, randomized controlled studies with serious randomized controlled trials with serious flaws or indirect evidence. And here are their recommendations. Zostavax. The Zoster vaccine should be given to patients aged 60 years or older if it can be administered 4 weeks or more before beginning highly immunosuppressive therapy. Strong evidence, low data to support it. However, I think that this would be one of the easier ones to decide on. If I was a patient and I had the choice, I'd want to do that. And the longer ahead, the better. Unless maybe there's another, that I had another contraindication. The second one, Zostavax should be considered for varicella-positive patients, that is, people with a history of chickenpox or another varicella-Zoster infection, or who are varicella-Zoster virus seropositive with previous doses of the chickenpox vaccine. And here's the hooker here. They're recommending that for people aged 50 to 59 years if it can be administered 4 weeks or more before beginning immunosuppressive therapy. They say weak recommendation with low evidence, and here's the asterisk in that this would be off-label use of the vaccine. It's not approved to be given in this age group, and it's not recommended by the Center for Disease Control. For the umpteenth time, I'd tell you, if I was in that position, particularly closer to 60 I would sure consider taking the vaccine. And then lastly, and most pertinent to our patients, Zostavax should be administered to patients aged 60 years or older who are receiving therapy considered to induce a low level of immunosuppression, and they call this strong with low levels of evidence. And luckily they define this for us, which I'm a low level of immunosuppression, which I'm going to give you. And lastly, Zostavax should not be administered to highly immunocompromised patients. Interestingly, they recommend it very strong, but there's very low evidence to support it. Using your mind to just think what you is most likely to be the result. Doesn't always work out, but it would seem that this would be the case. That is, you wouldn't want to give it to highly immunocompromised patients. And they define patients with low-level immunity.
Doesn't that mean that we probably will never know the answer to that question?
Yes.
It's like doing a randomized control study of throwing people off a building with a trampoline or without a trampoline. I mean, it's never going to get done.
That's right. And in fact, a lot of y'all probably aren't familiar with this, and I've got a few minutes I'm going to tell you. There was an article published in the British Medical Journal, forgotten what year, I think it was 2008, and they said they did an extensive literature search on the evidence to get evidence-based data on the value of the parachute, and they could not find any evidence. So they recommended that a randomized controlled study with crossover controls. Now this was published. I love it. And they solicited the people who were hardcore evidence-based people, insisting that you needed that kind of data before you published guidelines on it. Now this guidelines does not fit that hard data. And I'm pretty sure they never got any takers on that study. Their definition of low-level immunosuppression is those receiving daily systemic corticosteroids, glucocorticoids, with a dose less than 20 milligrams prednisone or equivalent per day, or receiving alternate day therapy. Now the faculty probably knows I'm a big proponent of alternate day glucocorticoids. On my myasthenia gravis patients, I try to start from day one on alternate day therapy. Almost all textbooks and literature will say or recommend starting with daily, and then after you get maximum effect, switch them over. And by starting with alternate day, you do probably lose some time, but it's not a great deal of time. I've never known that it got into trouble. And another benefit of alternate day is that it does not block the adrenal hypothalamic pituitary feedback. So if you abruptly stop alternate day glucocorticoid therapy, there is no known danger of adrenal crisis. And this may only be meaningful to a few of you. The first one that demonstrated this and published the fact that it did not affect the adrenal hypothalamic pituitary axis was George Ackerman, who was professor of medicine here, was chairman of the medicine department for a brief period of time, and he published a study that he did on chronic renal disease patients. He became a renal disease authority. He published this in the New England Journal of Medicine in the mid-1960s, and a major contribution to medicine. Let's see. And then pertinent to my patients, they say, as far as azathioprine is concerned, those receiving, they list others, methotrexate and 6-mercaptopurine, but also azathioprine. If the azathioprine is 3 milligrams or less kilogram per day, they define this as low level, and therefore these patients are candidates for immunization, vaccination with Zostafax. A little footnote that I might throw out is both the chickenpox vaccine and the Herpes-Zoster vaccine are live attenuated viruses, but the Zostafax, the Herpes-Zoster vaccine, has 14 times as much virus in it as the chickenpox vaccine has. So in my case one, what I was wondering when up until I read this was how long should I wait before he's completely stopped his azathioprine before recommending the vaccination. I think these guidelines are very good, and according to them, he was a candidate for the vaccination anyway. And then the next man, he's on a little higher dose. Now, both of these doses are low. Generally, myasthenia gravis patients have to take more than this, but both of them have done so well. He's 1.14 milligram per kilogram per day, but well below the 3 milligrams per kilogram per day. And I'll mention one other point, and I've repeated myself over and over again. Now, this is a man that has already had herpes zoster, and there has been some controversy in the literature whether or not these people should receive the vaccination. There is data to indicate that it's safe to administer it. How good it is to prevent them as a subgroup, that it prevents additional episodes of zoster, I don't know of any good data to substantiate that, but the potential bad with herpes zoster is so bad that I think it certainly should be a consideration. And that concludes it. I invite any comments. No comment. Yeah.
I have a related question that you might have some experience with. I saw a man recently who was referred from the myeloma center, and he was on acyclovir, and he had an episode months ago, which sounded very much like a Ramsay-Hunt syndrome. It was had hearing loss and ear pain. I didn't see any vesicles. So how much protection does acyclovir actually give you?
Oh, well, to a degree, I don't know, but I remember how if the
other people have you all seen that?
Well, now the lack of seeing the vesicles doesn't mean a lot.
No, yeah, that's right. I mean, it's not very classical.
And with geniculate herpes, the place you look for the vesicles, as you know, is in the external auditory canal and the tympanic membrane.
I mean, my theory is that the neurologist in his hometown just didn't see any vesicles and eliminated the diagnosis.
So he may not have known to look in the ear for the Now, occasionally, the vesicles will appear right around the meatus, but often you can only see them if you get an otoscope and look in the external auditory canal. And they're not all, it's only a part of the canal. The geniculate ganglia only covers part of the skin in the external auditory canal and tympanic membrane. What happened to that patient?
Well, he was going back to his hometown. He was kind of finished, but.
Now, did he still have facial weakness?
No, he never had facial weakness. He just had pain and some hearing problems. So some of it was also affecting the eighth nerve.
Well, now, with the Ramsay-Hunt, and unfortunately there are lots of Ramsay-Hunt syndrome. But with this one, they get facial weakness, but the tinnitus and decreased hearing commonly occurs in association with it. All right, any other comments? Dr. Greenfield, in Ohio, we talked a little bit about Lyme's disease. Did y'all see Lyme's disease?
We saw, well, like many places, there was a whole lot more people who tested positive and got treated for Lyme's disease than had Lyme disease. But there was some.
You know, we see there, it's not been confirmed by the state health department since 2007 in Arkansas. Okay.
Well, I think the has to do with the fact that the Ixodes, the mini tick, is really not prevalent in this part of the country. It's a very, very small tick, very hard to see, and that's part of the problem. People aren't aware that they have a tick on them.
Yeah, but
So they see
the initial part is a big rash.
Yeah, you get the target lesion. But I mean, by that time the tick's long gone, but you never really know because it's so tiny.
Okay.
Actually, I was parroting because I've heard that. Lucy mentioned that the parachute.
We took out the
How are you?
You know what, we were talking, someone gave me those, yeah, so I thought you had
That reminds me.
24 hours.
That reminds me of the.
You were talking about this thing.
About this parakeet.
We were talking about 24 hour doses, so I thought you were talking about 24 hours.
The guy has two strips
I don't really use that one.
and he's talking to the specimen. He's calling the right foot, he talks English. He's calling the left foot, he talks in French. The specimen says, what happens if I pull both during the same time? I swallow, stupid.
Well, I sure am glad you did something.
Well, I'm relieved. My brother hurt for about 6 months, but
Oh, he got
he
it.
got it about a year before I did. And I said, I'm sure it's much older than I am. And then I got it.
Is he still having bad?
No, he's over it. But he suffered quite a lot.
Not sure I even mentioned it, but well, I think it's really good last year. There have been reports that if you give him another course of encyclopedia, decrease the time of postherpetic, which is probably what I would do.
Oh, well, the report came out when I was there. Yeah, 30 years ago. It turns out there was young moms in this town in line whose kids were coming out with fights and they were being diagnosed with juvenile. And I said, this doesn't make sense. You know, our kids are getting this. So they went to Yale and after this happened.
Will you be able to request your
What I used to do with the gamma gun. I used to look right into the gamma gun. It was, what's his name, Solitas.
So that's kind of where it got started.
And she has permanent damage from that disease. And so had been diagnosed so lingering other symptoms that severe type problems, stroke symptoms that had come from neurological because they didn't know what it was.
Plus the atrophy is our heart.
Yeah, I mean, it wasn't their decision.
Yeah,
Yeah, but
but
this is my outside
walking a lot.
perspective.
That was okay. Now she was retired to Wilmington, North Carolina. And she said, now that I don't have to she said, I realized that arthritis is worse than because, and of course, those symptoms they were treating that, they were treating all kinds of things for her that were not wrong. So I'm very well acquainted with that hereditary, abnormality.
Yeah, it's gonna be different kinds of.
In my case, I was gone for 3 weeks. Deer came late, every Caroline, all my hostas, and then once they finished those, they started with the familiars. And I just wanted to children in my neighborhood playing in the house. Deer tick. That's what I started.
Yeah, but the particular tick, the Ixodes tick, it's not part of its range. So they're in the northeast and the Midwest, Wisconsin, Michigan, Illinois.
With a tick or a parasite on the tick, we learned like
Well,
plague, it's not the rats, it's
but the tryptamine that carries it only lives in this tick. So
I mean,
it
you
can't-
guys
Well, I wondered about that, of course, we had to eliminate all the neighborhood.
Right.
Well, that's a different story. No, but the deer tick are not
We're constantly fighting more of their
at fault.
time. The percentage of
Dr. Lucy,
Ma'am?
a woman in my church, a good friend, had
more shingles. So I'm hoping we back up the nerve first.
and she
Once
almost
she's
lost
up
an
and
eye.
running,
She's a professor at Yale. So she
Then
warned all of us that I get the shingles vaccine. So now this was maybe 6 or 8 years ago.
Mhm.
And so I couldn't find it. I found one pharmacist in a neighborhood, in an office building who was giving it, and nobody had the vaccine then. So
Well,
I went.
now doctors wouldn't keep it in their office
No, I
for
know,
two
but this was,
reasons.
but.
Real expensive.
Well, but, I mean, I couldn't even find a pharmacy any, but this one man, I finally found a place to get it. So I went out and paid a lot of money for it. He never asked me what medications I was on, what diseases I had had, but I left in there, and I wonder how many people have gotten that, or maybe it's caused worse symptoms because no one during that period was asking any of those relevant questions.
Well, now that probably was a pharmacist that gave it to
It
you.
was,
Yeah.
but if somebody can go around the medical system,
Well,
is there a danger there?
like the way you do it here is, you have to get the doctor's prescription, then you take the prescription to the pharmacy, then the pharmacy will get the medicine, and you take it back up, and your doctor's nurse will give it to you. Now, if you go to a doctor, they're probably gonna ask, they want to know something about you.
Well, then after that, when I began to be a patient here, I let them know I had taken it because I didn't know if it might be relevant to something else, but that was pretty, now that I've seen this, I just wonder how many people.
No other family members?
Before it was.
Thank you, Dennis.
Yeah, thank you.
Did that, and maybe there was consequences of that no one realized at that point.
Oh, well, some of this data
Yeah,
is
well,
just
so,
particularly
yeah, absolutely. So what I'll do
vascular.
is,
Knowledge about that is just developed
Exactly.
fairly recently.
I mean, I unfortunately didn't know early on.
Now your friend, sounds like now she had ophthalmic division of the trigenital nerve involvement. That can cause a lot of trouble. And one of them is with the cornea, so you need an ophthalmologist to take care of
She
your
was
eye.
had very good care, but she just scared her so badly, they were able to control it before and
the reason I
compromise
ask
her
is
vision.
different
But
institutions.
she was warning all of us, don't go through this, please get your shingles vaccine. And so we all ran out and did so. But I just wonder, how much control there was of getting as far as if you could go out and get it from a pharmacist, there was no, idea of asking about any, she didn't ask me if I was on any medications, if I had any diseases or anything.
So some colleges
Yeah,
I know.
now, that's something that has developed
Euler is really good.
just within
Usually I
recent
ask for stuff.
years, I don't know how long. I
So
drive
they're going to
my Walgreens out there, and they advertise,
Yes.
get your shingles shot here.
college students for sure.
How many questions they ask.
Well,
None of them
yeah, I don't
want
think
the
that's
accommodation. None of them
optimal,
want to go
but
through
the
this.
pharmacist would say, well, you're just trying to protect the MD's turf.
Exactly, but it seems to me that since
you
doctors have such incredible
And you guys are
malpractice,
trying to get from here to there. Wouldn't it level the playing
Things
field?
built into their practice, but
Without that,
pharmacists,
the interesting is
I mean,
certainly
do they even have
and it's sort of the same.
malpractice
It's
or
the same.
whatever? Now
Yeah,
that they're
yeah,
giving
that's
insurance and all
insurance.
that.
Yeah, they have.
Because
They
we're
have.
being
responsibility
with this neurologic condition, they are not. It's like having a
Feeling
birthday
that
at night.
responsibility. And now with compounding pharmacists, you can walk in and tell them anything and they'll fix it up for you. It's pretty scary. This was a great presentation.
Examination time examinations is just like a and it puts you, it levels the playing field. It doesn't mean that, now there's certain jobs where you need to stay with those careers. But in terms of getting through school, yeah, why not take advantage? And you don't have to. I can ask for the accommodations. Office of Disability Services can grant them. You don't even have to take advantage of them if you don't want. If you think you're doing fine, you don't do it. But they're there for
There
you.
wasn't a sign-up sheet
You know
for
what?
students at the beginning, and it was passed, but I don't know how many.
And I can ask for all kinds of things, like
I
it's
brought one,
like
of course, told everybody.
and without losing
Thank you.
scholarships or extended time exams, extended time on standardized exams, like additional SATs for high school students. I can ask for all that kinds of stuff. I can ask for designated note takers in class, so that they don't, somebody who has motor problems isn't having to keep up with the notes. Yeah.
Note takers.
Yeah, so all that stuff, computers, I mean, you can ask for, and again, at Euler, they're pretty good about granting that stuff. Yeah. I mean, although the good thing is, that I know who I can send an email to when my kids are over there. Just check it, you can always let me know if there's an issue. It's just, oh, okay, on a totally different note, so he said, and he was just seeing the stranger rush. So I just want him to start seeing him before we get manual. And so I just need to know sort of how far out he's scheduling.
He lives here in Laurel?
No, he lives in Chattanooga. So he's gonna come over, he's gonna plan his trips to see us around.
So you give me a date and we'll make it happen.
Okay, well, I mean, generally how far out? I mean, we're talking.
This is stuff Dr. loves to do stuff like this. So you give me a time and we'll make it happen.
All right, well, I'll call him. But I was thinking like.
No, that's fine. You let us know and we'll make it happen. And so, yeah. If we could do, look, right now, he used to do the, Wednesday, the chief resident clinic, and he's not doing that, so we still have some Wednesday afternoon right
So we'll
now.
make sure that it's on Wednesday.
Or if not, we could do it on Friday. Some of them are, them are the ones that weren't open until recently, and we still sort of have control over booking those
Okay,
slots.
all right, good, well, I'll let you know.
Yeah, give it me. Yeah, the next week if you
Yeah,
can,
I will.
I'll make it that way, because he's off a couple weeks in November or a week in October, because he was planning on maybe going to a conference.
Okay.
But yeah, I'll just say yes, no, and.
Thank you.
Okay, that's fine.
Next prospective, you see